Yeah, Niranga will join in a minute also. We can see Manjula sir on board. Welcome, sir, to the Uromet.
Thank you. Good evening.
Good evening, sir.
So Niranga is doing the basic physiology, no?
Yeah, basic physiology and pathology of neurogenic clot, sir.
That is the thing. So without him, you can't even ask a question.
Exactly, we have combined female urology and neurourology. Both are very. Actually, we'll have another 2 Uromet sessions. The last one would be on basics and principles, the topics which were not covered during the previous Uromet. We will cover in that last Uromet. So we have another 2 Uromets to finish this season number 2.
Taha, best to get Professor Ajit Malasekara's update on about the status of the MCQ exam.
Maybe Ranga is trying his best. Can you move to the next talk, sir? It's on aerodynamics basics.
I think so. I think so. I think so.
Nishanta, my co-moderator, Nishanta Wilson, can you introduce the speaker, please?
Our next speaker is Dr. Satyamurthy Prasanna. He will be talking about basics of urodynamics study.
Good evening, everyone. Thank you for being here. Today, my presentation is basic of urodynamic study. So today presentation objectives are, so we are going to introduce the basic component of urodynamics, how you can get good information without urodynamics, and what are the component of urodynamics, how to get the best information from urodynamics studies, and when they are indicated and when they are not indicated. So this urodynamic studies, it objectively assess the function and dysfunction of the lower urinary tract. That means bladder, urethra, and the sphincter. So main goals are reproduce the symptoms. That means when patient presenting with symptoms, either voiding or storage symptoms, and when we are doing the urodynamic study, we have to able to reproduce the symptoms and answer specific clinical question, and establish a precise diagnosis and determine the severity of condition and plan for further investigation and the therapies. So before going to go ahead with the urodynamic studies, always we have to explore the UTA, because this urinary tract infection can mimic like a lower urinary tract symptoms. It can cause the LUTS, so it will misinterpret the urodynamic our diagnosis and the result. So when the patient present with the LUTS, so when present, we have to get the history and examination, and we analyze the symptoms, and we work out the scoring system with the scoring system, whether it is bothersome score to the patient. Then we have to do the urine analysis to exclude the UTA. Then we can do the ultrasound and PVR and think about the conservative management, which include minor medical management and the other like pelvic floor exercise or biofeedback exercises. Those are the conservative management. But if the failed things or any diagnostic dilemma, then we can think about the free flow rate. That means the non-invasive urodynamic studies, and then cystometry and pressure flow studies. Those are invasive ones. So this is the normal workout for the when the patient present with the lower urinary tract symptoms. So in the sets of there are urodynamic studies are there can be either non-invasive or invasive ones. So non-invasive frequency volume chart here. So within the 24-hour period, we are calculate the functional bladder capacity. That means the patient's voiding capacity, voiding interval, and total urine production. So these things we are ask the patient to mark in a frequency volume chart. Then other one is the bladder diary. This is usually done for the 72 hours period, and here we ask the patient to mark the symptoms and is there any evidence of any events, mainly the incontinence. It can be urge, stress, or mixed one. So we can ask to mark. Then intake, fluid intake, and those things we have to ask for the 3 days period. That is bladder diary. And pad test. This is usually for the incontinence. We can ask the simple test. We can measure the pad pre and post procedure and ask the patient to do some tests like coughing and walking things, and we can measure, and we can objectively we can assess the any significant incontinence is there. Then uroflowmetry and post-voidal residual volume. Either this we can measure with the ultrasound PVR, or after uroflowmetry we can catheterize and measure the post-voidal residual volume. Then there are invasive dynamic studies. This is cystometrogram. That's mean storage in the, as Niranga mentioned, the storage and voiding phase. In the storage phase, we can measure the cystometrogram. And then in the voiding phase, we can do the pressure flow study. Then electromyogram, fluoroscopy, it's sometimes might help the fluoroscopy and the urethral pressure studies. So role of urodynamics in clinical practice, according to the American Urology Association, to identify or rule out the factors contribute to the LUT symptoms. That means LUT dysfunction. So then if the other than this above LUT dysfunction, there any other aspects, then we can, to rule out those things, we can do the urodynamics and predict the possible upper tract deterioration. If there any involvement of upper tract and there's a deterioration, then we can predict with the urodynamics and predict the outcome of intervention and effect of certain treatment and understand the treatment failure. Those things, even after treatment, we can do the urodynamic study and we can compare. So when we look at the uroflowmetry, it's a simple test, and patient void and flow is measured. There are machines, are newer machines are without this wireless machines are there. So it's expressed in ml per second. So minimum voiding volume should be more than 150 or 150 to 200 millimeter should be there, and normal curve is a smooth and bell shape or inverted U shape curve, and must be combined with the intravesical and intraabdominal pressure according to more specific. So if you want to go ahead with the more specific test, then you have to combine with the cystometrogram or gram, but otherwise usually this is the basic test. And so this is the basic uroflowmetry. So there's a volume we can ask the patient to void, and it can be wireless or via connected one. Then in there's a machine, it can measure the volume. So the upper one is the normal curve. It's a nice bell-shaped curve, and this lower one is the plateau one. The plateau dotted line is the mainly for the constrictive pattern. Constrictive pattern means that's a plateau phase is mainly for stricture disease, and the solid line is the lower one. Solid line is compressive pattern. It's mainly for the obstructive bladder outflow obstruction, like bladder benign prostatic enlargement, which causes the bladder outflow obstruction, can be the solid line. So flow in men, it's around 15 to 20 milliliter per second, and less than 10 ml is significant. Sometimes less than 15 take as significant, and flow rate declines with the age. So 1 to 2 ml per second per 5 years, there's a decline is there, and decline in peak flow with age result in normal Qmax around 5.5 at the age of 80. This might be a normal Qmax for the 80-year-old gentleman. When we compare to the woman, so compared to men, the woman's this Qmax is a little bit high. It's around more than 25 to 30 ml woman's Qmax, and because of there's a small short urethra, and it's influenced by strength of detritus, and the urethral resistance is very low, and the urethral relaxation. And there's no significant this age variation is there. Then, so this is regarding the uroflowmetry. And when we look at the invasive test, that means cystometrogram and the pressure flow studies. So when we measure we have to first place the machine. So there's two pressure ports are there. One is the intravesical pressure, other one is the intra-abdominal pressure. To measure the intra-abdominal pressure, we can keep the transducer into the rectum or in the vagina to measure the intra-abdominal pressure, and we have to fill the bladder in the physiological rate. In the physiological rate, we have to fill the bladder. So when we fill the bladder, we can take this storage part of the pressure studies. So that means in the storage phase, we can take that is called cystometrogram. So, and then when the patient passing voiding the urine, that is pressure flow studies. So when we look at the normal So how to read the urodynamic studies? So bladder has two phases as mentioned, storage and voiding phase are there. So it can be problems can be either bladder or outlet. Outlet means with a sphincter or both. For example, so leak due to uninhibited detrusor contraction. That means this detrusor overactivity. There may be a failure to store. There may be a storage failure. That means that there may be a incontinence. And when the woman that leak with cough or strain, that's the stress incontinence. So normal cystometrogram. So that means in the storage phase, it can measure. Usually we can measure the capacity. That means the normal bladder capacity and sensation, which volume they can feel the sensation, and the compliance of the bladder and contractility. So in the cystometry, we can measure these things. So in the first sensation, that means when the patient, when we fill the with the normal saline with the physiological rate, when patient feel the first sensation, usually occurs at 90 to 150 ml. Then when the first desire, this is normal. When it is first desire occurs around 200 to 400 ml, patient feel the first desire. And strong desire, it will occur around 400 to 600 ml volume. Patient feel the strong desire to void the urine. And when we look at the compliance of the bladder, it is calculated by the volume over pressure. That means if we give the particular volume of saline and when we measure the pressure, intravesical pressure, that is called as compliance. So if it is less than 10 to 15 milliliter per centimeter water is called as low compliance, and if it is more than 20 ml per centimeter water is it's called as normal compliance. And the normal capacity of the bladder is around 300 to 400 ml. So this is the again just a diagram. So we can one pressure transducer into the bladder, and other one within the, so one is within the bladder and the other one within the rectum. So we can measure this rectal transducer is taken as the intra-abdominal pressure. And when we subtract from the abdominal pressure into the vesical pressure, we can take as a, sorry, other way around. From the P vesical minus P abdominal pressure, it called as the P detrusor pressure. So this is the normal graph. So when we look at this normal graph, this initial part of this graph is called as the voiding phase. So this up to this phase is the voiding phase. So this after this, my purple color one is the, sorry, this initial part is the storage phase, and after this violet color one is the voiding phase. So when we interpret the urodynamic study, that means cystometrogram, so first we have to look at this storage phase. In the storage phase, first we can see this detrusor pressure, whether it is detrusor pressure is in the baseline. If the detrusor pressure is in the baseline, that means there's no contraction. Even with the filling of the bladder, there's no contraction in the detrusor. Then that is normal.
Prasanna, you have only 5 minutes.
Yes, sir. And whenever there's any increment in the or increase in the intra-abdominal pressure, it will transduce in the intravesical pressure. So we can see whenever there's a intra-abdominal pressure is increased, there's a same intravesical pressure also increasing. So that is this graph is normal. So this is the original graph. Here the initial phase is the this initial part of the one is the filling phase. So in the filling phase, we can see the lower one is the red color one is the detrusor pressure that is in the plateau. That means that is there's no any increment. So that is detrusor activity is normal. So there are two stress. Usually they will give two stress. That means we can ask the patient to cough. So there's a increment in the intra-abdominal pressure. there are two stress are given, and it is transmitted to the intravesical pressure. So there's a there are two intravesical pressure also same. There's an increment, but in the initial part there's no any leak. There's no any significant leak. So this is there's the normal graph, and there's no any stress incontinence. So with the increment in the intra-abdominal pressure, there's no any leak. So pressure determined during the urodynamic studies. So Valsalva leak point pressure is the intravesical pressure at which leakage occurs as a result of an increment in P abdomen. That means pressure abdomen in the absence of dead pressure contraction. So without any dead pressure contraction, if there's any leak occurs, that is the Valsalva leak point pressure. Then other one is the dead pressure leak point pressure. That means the lowest P dead pressure at which leakage occurs in the absence of a dead pressure contraction or rise in P abdomen. So without any intra-abdominal pressure increment or dead pressure contraction, is there any leakage due to the that means that there's a sphincter problem. Then when the compliance measured at end fill pressure or pressure before leak contraction. That means thank you, sir.
Okay, thank you, Prasanna. I think to better know some basics, the mechanism of uroflowmetry as well. Sometimes they might ask how the uroflowmetry machine works. Experts, Manjula sir and Suren sir, any comments?
So Prasanna,
Yes, sir.
Suren, is it okay if I go first?
Yeah, please do. Yeah.
Prasanna, now have you set up a urodynamics testing in your training?
No, sir. We are the most juniors. Just we have started just 3 months back. Even I didn't see the urodynamic machine in. I didn't see, sir.
Now the thing is, there is a very important thing called quality control in urodynamics.
Yes, sir. We have to adjust this pressure.
So what comes to your mind when you say quality control in urodynamics? What factors you would pay attention to? Now, I will try to help you. Now, suppose you are going to do the pressure flow studies. So you have to, set up instruments, cannulate the patient, and take a recording.
Yes, sir.
So if you are not very attentive to the quality of the recording, ideally the urologist who is doing the urodynamics reporting should be present in the room to do the testing. It's not like taking a ECG where a technician will take, you interpret it. Here,
Yes.
since you want to replicate what the patient feels for the symptoms, the urologist who is reporting should be present at the time of testing. So that is number one.
Yeah.
So in the quality control, the number one is the specialist, the urologist specialist, who is going to report on the outcome of the report should be present at the time of testing. Right. So what are the other things you can think of?
And this tracing should be reflect the patient's symptoms. Actually, if the patient coming with any incontinence or anything, the tracing should be reproducible for the patient's symptoms.
Well, if we start from the beginning, Prasanna, first we need to formulate a urodynamic question. So that is the number one. So suppose there is a patient with low urinary symptoms, you are thinking of having a urodynamics. First, you have to have a hypothesis that this patient is having this problem. Then only you can find an answer. It's like you're sending somebody for an ultrasound scan without mentioning what you are looking for. The radiologist will not be able to help you much. So if you are thinking, well, this lady, this female is having stress incontinence, then you will formulate the question saying the patient is having genuine stress incontinence. Then only you submit the patient to urodynamics. Without having a hypothesis or a question, urodynamics can't help you. So that means you formulate a question, then you try to find an answer to it. It's not like, shall we do a urodynamics and see what is wrong with the patient? That won't work. So that is the second one. Third one is, when you set up all these lines, if you have seen now, some of the probes are, fluid fill lines. The lines that are going into the bladder to the rectum, they are fluid columns. So what would happen if there is an air bubble in any of those? What do you think? What would happen to the tracing?
It will show the reduction of.
There is a thing called impedance. So the real pressure inside the bladder or the rectum will not be shown on your computer screen, because there are a little bit of blunting of that pressure transmission. So in the quality control, it is very crucial that you fill the lines without any air bubbles. Right. So that is the next point. Then the point after that is, you have to zero the lines to a particular value before starting the recording. So to what would you zero the lines to? You have to have a zero line. So what is the standard zero line you are using? For the pressure to be recorded, let's say 0, 5 centimeter, 10 centimeter, 15 centimeter. Where is the 0?
I'm not sure, sir.
0 is at the patient's pubic symphysis level. Just like for CVP, you have to have a right atrium as the 0.
Yeah.
Symphysis pubis level is the 0 line. So all the recordings are from above that. So you have to set up your instruments. The newer urodynamics machine, you don't need to zero because they are solid state devices. But for the fluid filled manometer lines, you have to zero the patient's body to the machine. Okay. So now you are running the recording. So what is the quality control before you really start to fill the patient up? What is the quality control step you are going to do? So now you have set up the machine and it is running. So a recording is appearing, but you are not filling the bladder. Your saline is still closed. So what is the quality control step you are doing at this stage?
We have to determine which flow rate we are going to fill. That means the physiological, which rate of the.
Right. Okay. So what is the usual fill rate?
Point.
What is the usual fill rate you use for the urodynamics?
No, I'm not sure, sir.
It's 50 ml per minute. But what I wanted to know is that you have to get a good subtraction. So that is the next quality point. So that means you have to ask the patient to cough and see whether the P abdominal curve is totally cancelled by the P dead curve. P vesical curve, sorry. Each has to cancel so well, P dead curve should lie flat. Without achieving that, you can't run the fill. Because you have to have a good zeroing, you get a level. After that, P abdominal curve should be nicely subtracted from the P vesical curve to get a P dead flat curve. Once the P dead is a flat one, only you should start filling the patient. Right. So you realize there is some quality control. Quality control is so important. Otherwise, all your inferences are going to be wrong. Okay, Suren, over to you.
Yeah, I think you covered the most important things. That the urodynamic test is a very the standard ones we do is all with pressure lines filled with saline, and without all of what you said, the tracing is useless. So I think you've dealt with most of the things, and once you've done all of that, got the subtraction is happening, then of course ideally, like what you said, the urologist who's questioning, who has this clinical question, should be there observing the entire test while it's being done, because these are very subtle changes, and sometimes if you repeat it, you don't get it. That is a problem with urodynamics, that in the same patient, if you repeat it, sometimes you don't get the initial result. So it's very important that I think what you discussed is the main thing. Yeah, I don't know whether we have time now to go to the next stage of talking about the two main things we need to know in doing urodynamics is, at least as clinicians, is the detrusor overactivity and is there bladder outflow obstruction. Those are the two main things that you need to know. I mean, there are a lot more information that you can get, but these two are absolute basics. So I don't know whether we have time for that, or are we handling that later on?
We might ask some other questions during the other things, no, sir? So
Yeah.
shall we? Thank you very much.
Question to Prasanna. In your urodynamics tracing, during the second cough, there was a leak, no? What was there? The interpretation of that tracing. And one more thing, how do you decide the physiological filling? What is the rate? How do you calculate the physiological filling? Is there any formula for that? So it's usually body weight divided by 4. So in normal filling would be 50 to 100, but if you suspect, as Manjula has said, we have to go with the question. And if you suspect a neurogenic bladder, then you have to fill the bladder slowly closer to the physiological filling. And read about bladder contractility index. There's a formula. Read around that. Yes, Nishanta, you can move on, please.
Yeah, I think we'll continue as Niranga is joined, so we can continue his presentation, no?
Please.
Yeah, Niranga, over to you.
Okay, sir. Can you hear me, sir?
Yes.
So it comes to the bladder mechanics. There are detrusor muscles which contain these M3 receptors, and there's a nerve supply which is by the parasympathetic ACH neurotransmitter. When we consider in this mechanism of muscle contraction, calcium enter via these calcium channels, and this contraction compared to this skeletal muscle and cardiac muscle, detrusor contraction is slower and long lasting. This is modulated by this actin myosin modulated normal physiological contraction. And the specific feature is, even in a normal bladder, there can be spontaneous activation and contraction waves. This is done by the myofibroblast in the detrusor layer, which can act as a pacemaker cells. Hello, sir. Can you hear me?
Yes, we can.
Carry on. Yeah.
Okay. I'll continue. Okay. So when we the most important slide is this neural control of the bladder innervation and the activity. When it's come to this motor innervation, there are three main innervation. One is this parasympathetic pathway, sympathetic pathway, and the somatic pathway. In the parasympathetic pathway, the preganglionic cells lies at this S2S4 level, and they are synapse at the detrusor muscle level with the cell bodies. So their action will be in the detrusor muscle level. They are excitatory, and they will cause the detrusor muscle contraction. And when they are supplied toward this bladder, neck, and urethra, they are having an inhibitory function. So they will relax. So their overall action towards the micturition. So they will contract the detrusor and relax the lower sphincter complex. When it comes to sympathetic supply, they start from this T10 to T11 level with preganglionic cell bodies, and they will transmit along this hypogastric plexus nerve complex, and they will have the predominant action of inhibitory action over this parasympathetic action. So they will inhibit this detrusor activity, as well as they will have excitatory action on the bladder trigone and sphincter level. When it's come to the somatic pathway, which is under voluntary control, which is the motor nucleus located as the spinal level on this on-off nucleus. So it will start from S2 to S4 level, and these fibers will transmit in pudendal canal via this pudendal nerve, and they will have this pelvic floor and external sphincter contraction under voluntary control. Also, this bladder, it has this apparent pathways toward the spinal cord. They also are transmitted using the same nerve pathways. So there are submucosal neural plexus, and there are detrusor muscle in the bladder. So they will send these apparent fibers along the same sympathetic parasympathetic pudendal nerve fibers toward the spinal cord via A delta and C fibers. So this parasympathetic, as I mentioned, they are postganglion detrusor whole layer and pelvic plexus. Sympathetic will be transferred via this inferior mesenteric ganglia to hypogastric nerves, and somatic will start at the ventral horn with Onak nucleus via pudendal nerve. As I mentioned, this apparent via this myelinated A delta fibers is the predominant one in a normal reflex. So they will respond to stretch, nociception, over distension, and wall tension via smooth muscles. When it comes to spinal and supraspinal control, we have a Onak nucleus at the spinal cord level. And then the brain stem, we are having this pontine micturition center, which is located at this dorsal pontine tegmentum. And we know this complex as a Barrington nucleus. And in the midbrain, there's area known as this periaqueductal gray matter. And from there, it will ascend to the brain in the prefrontal cortex and anterior cingulate and thalamus area having the central control. When it comes to the bladder, there are filling space and storage space, which was described by the previous speaker as well. In the filling phase, there are 3 phases. The initial phase is the gradual filling, and there will be increased intravesical pressure. After that, the intravesical pressure will kept low and constant by this physiological phenomena known as this receptive relaxation. So the bladder compliance play a major role in keeping this intravesical pressure low during the initial filling phase in the phase 2. And when it's come to phase 3, there will be a sense of voiding. So in the voiding phase, phase 4, the volume will be around 420 to 450, close to 500. There will be this relaxation of the external sphincter and detrusor contraction. This will coordinate by higher centers. So in filling phase, there will be accommodation of the urine with the normal compliance and keep the bladder outlet closed in spite of increasing abdominal pressure. In the absence of involuntary bladder control, there should be no detrusor overactivity. When it's come to micturition, there will be coordinated bladder smooth muscle contraction, relaxation of the smooth muscle at the bladder neck, and there should not be any anatomic obstruction in the urethra. So when we are considering this neurogenic low urinary tract basis, it should be either failure to store or failure to empty. If there are bladder defect, there can be overactive bladder, decreased compliance, or there can be a combined defect, or there can be outlet defect in storage, which can give rise to stress incontinence, pelvic flow, or sphincter dysfunction. When it's come to a bladder defect in emptying, there can be bladder underactivity as well as functional dyssynergia. So when we consider this neurogenic low urinary tract dysfunction, the detrusor overactivity, it is idiopathic in 11% studies. There's imbalance in local neurotransmitter and urothelial dysfunction. And they can have this stress urinary incontinence. Male in female, there can be intrinsic sphincter dysfunction. In nocturia, the physiological basis is there can be a circadian rhythm expression of local neurotransmitter with reduced bladder capacity. And they can have this underactive bladder as well. There can be detrusor underactivity with decreased neuronal efferent. And one important thing is this spinal cord injury, which causes neurogenic bladder. As I mentioned previously, in normal reflex, there's a spinobulbospinal reflex, which is normally mediated by this myelinated A delta fibers. But when there's spinal cord injury, this will be mediated by this capsaicin sensitive C fiber, predominant reflex. So this will cause us detrusor overactivity and injury above sacral spinal level. So there can be initial spinal shock during initial phase, giving rise to urinary retention. So we can classify these spinal cord injuries, whether they are supraspinal, suprasacral, or infrasacral. In the supraspinal phase, there will be a central disinhibition over this spinal reflex. So spinal reflex will work on its own. But there will be loss of central control. So there will be a micturition without a proper control. But at this level, the bladder pressure will be safe with a low pressure bladder, which is autonomy. When there's this suprasacral lesion, L5 to Pons level, there will be complication like this neurogenic detrusor overactivity or detrusor sphincter dyssynergia. where the synchronous contraction of the detrusor and external sphincter occur together, giving rise to high intravesical pressure. So this increased intravesical pressure is unsafe, and with high pressure, they can transmit it to upper tract, giving rise to upper tract dilatation. From below that level, corners to peripheral nerve level, all are considered as lower mode type neuron lesion. So there will be a non-contractile areflexive bladder with a sphincter weakness. So this, even though we mention like that, depend on the neural lesion, there can be complex lesion, depend on the detrusor activity as well as the ureteral sphincter involvement. When we consider this blood outflow tract related lower tract symptoms, this occurs due to this irritative voiding symptoms because of the denervation supersensitivity. So this will increase the receptor mediated bladder contractility. And there's another entity called this bladder pain syndrome. So there will be inflammation and alteration in signaling pathways in interstitial cystitis. And the other thing is this aging. With the aging, there will be reduction in bladder capacity and alteration in this collagen fiber, bladder contractility, and this neural hyperfunction can give rise to incontinence. And specific management of these neurogenic LUTs will be discussed in next presentations. Thank you, sir.
Thank you, Niranga. Yes, sir. Do we have any comments? So,
Manjula,
I
sir,
think-
sir.
Yeah, I think Niranga is dealing with the basic science. To save some time for the clinical issues, I think we might move without questioning Niranga on this subject matter.
Yeah.
yeah,
think
yes,
so?
Yeah.
yes, sir.
I agree. Yeah.
Yeah. Next topic is about the overactive bladder. That will be done by Dr. Dinendra Madhushankar. Dinendra, over to you.
Hello, sir. Can you see the slides, sir?
Yes.
Yeah. Thank you.
Okay, good evening. I'm going to discuss about topic about overactive bladder. My previous speakers discussed about the physiology and the derangement of the bladder. And then here we discuss about the overactive bladder, which is basically a storage pathology which related to bladder. And it is defined by its urinary urgency, which is accompanied by frequency and nocturia. And there can be either involvement of incontinence, urge incontinence or not, and there shouldn't be any pathological problems like UTI or any obvious other pathological related to urinary tract. So the hallmark of this overactive bladder is detrusor overactivity. And how do people develop overactive bladder? There are various theories.
Sorry to interrupt you. Can you move to presentation mode?
Okay, sir.
Good. All good.
Right. When we discuss about the pathophysiology of this overactive bladder, there are various theories which is discussed about. There is imbalance between the inhibitory and the excitatory neural pathways to the bladder. We all know now the neural pathways, there are afferent and efferent pathways to the bladder. There is imbalance between this inhibitory versus excitatory pathways. And same time, there is sensitivity derangement in the bladder muscle receptors, which will lead into overactivity of the detrusor muscle. But those are theories, but exact cause is not identified. The etiologies are being a female gender and aging and other risk factors also contribute to this overactive bladder. And classification wise, they divide into whether it's associated with urge incontinence, so either it's wet or dry, depending on the incontinence. And when we come across with a patient with urge incontinence or urgency, to diagnose overactive bladder, first we have to go through the history and examination. And same time, we can use the basic investigations like urine analysis to exclude either associated UTI, hematuria, and other pathologies. And the test which is helpful for this diagnosis are there are questionnaires which is set up to diagnose how severe the urgency and the involvement, and we can use bladder diaries, or we can use this flow volume chart where they advise to get the readings of about 3 to 7 days about the patient symptoms, and there we can assess the input and as well as the output same time whether there's an associated incontinence situations. And in the initial assessment, they don't advocate to go for urodynamics. Only the history examination, this flow volume charts, those are enough. But when we go for second line evaluation, the advanced investigations like urodynamics, the cystometry, those things should be involved. In urodynamics, there we can establish the involvement of the detrusor overactivity, but sometimes there are certain groups where still detrusor overactivity is not there, still the patient is having overactive bladder. And by doing urodynamics, we can come into conclusion and patient will benefited by early treatments. And these are some urodynamic studies. Here you can see when there's filling phase of the bladder, with the increasement of the bladder pressure as my colleague described, there will be detrusor pressure rise also. And the EUA described about these newer techniques like urinary biomarkers, which is seen in patients who are having overactive bladder, which are NGF and DNF, but they are not routinely practiced, they are still in research level. And once we diagnose a patient with overactive bladder, then in the management, there are basically conservative management as well as surgical management. EUA recommend initially start with conservative or non-surgical approaches, and then later on, depending on the response, advance into surgical approach. Non-surgical therapies mainly involve there is lifestyle modifications, as well as then we can go for pharmacological treatments. And before treating these patients, we have to just think about the other factors which can confound these symptoms, like they are having other medical conditions, so we have to pay attention to them and treat them accordingly as well. Then what are the lifestyle modifications or the interventions we can do? We can do fluid intake adjustments where we can modify their intake, and but this should be targeted on their assessing. First we have to assess their 24-hour fluid intake as well as urine output. By that we can advise them on modification of fluid intake, and it will help about 25% to improve their overactive bladder symptoms. And caffeine intake has also somewhat including these symptoms, so we have to restrict caffeine intake. And weight loss also plays not much of major role in overactive bladder, but it has associated symptoms, blood symptoms as well as incontinence patients. So if the patient is having incontinence, weight loss plays a role, but it doesn't mainly act on overactive bladder. And smoke cessation also helps in reduction of symptoms. And we can advise them on behavioral and physical therapies. Yeah, we can use prompt voiding versus timed voiding. Prompt voiding, which usually apply for patients, usually for caretakers, where they will advise the patient to urinate in a given time and to prevent this urge incontinence. And time voiding, where we set up a defined time frequency to patients to pass urine, and it will help in reduction of the symptoms. And they describe bladder training, where again patients' urination pattern, those things are reset into a healthy manner, thereby patients' fault patterns, frequent urination, those things can be improved, and patients later on, the urine frequency as well as the urine volume can be improved, and it will help in reduction of overactive bladder symptoms. And we can advise them for use these pelvic floor muscle exercises. There are various programs or set of muscle training areas where they can increase the strength of pelvic muscles. Thereby, the randomized control trial has proven that it will help in significant reduction of overactive bladder symptoms. Another aspect is where we use electrical stimulation. Thereby, it will increase the muscle tone and it will reduce the symptoms. The methods are they use posterior tibial nerve stimulation, where we can use either transcutaneous PTNS or the percutaneous method, where the nerve stimulated, and it will reduce mainly the symptoms. And by doing this lifestyle modification and the electrophysiological treatments, then we can go for pharmacological treatments. Pharmacological treatments mainstays played by anticholinergic drugs, which is the mainstay, and it will reduce the symptoms, and which is proven by a lot of trials. And there are set of pharmacological agents are there, and the common side effects which is confined to them are they cause significant dry mouth, cognitive impairment, UTIs, and constipation in patients. And these are some examples of anticholinergic agents we are using in our practice, which are oxybutynin, sulfenazine, tolterodine, and there are, you can see from the graph, those are effective in treating overactive bladder. And other agents are, we can use beta-3 agonist, where these beta-3 adrenoreceptors are situated in the bladder, detrusor smooth muscle, and by stimulation it will cause detrusor relaxation. So the drugs are, we can use mirabegron, or same time we can use, there's a vibegron, which are also as effective as they, from the trials, they shows it is as effective as antimuscarinic agents in controlling some symptoms. And then after the medical treatments, we can come into surgical treatments, where we can use bladder wall injection of botulinum toxin A, which is a muscle relaxant agent, which we inject intravesically, and it will cause relaxation of the bladder, and it will reduce these symptoms. But the drawbacks is, by giving botulinum toxin, it can cause more relaxation of the bladder. It will propend to get UTIs, and some patients will develop high residual volume, which they might need intermittent catheterization even. But it is helpful in reduction of overactive bladder symptoms, and we can repeat these treatments as well. And we can use sacral nerve stimulations, which also a proven treatment, where we implant some nerve stimulants to the sacral nerve roots, and the device is implanted to the buttock, where it will emit some neurostimulation, and it will help in controlling bladder overactivity. And EUA also suggests that it has some proven benefit in controlling symptoms. And other surgical aspects are, we can use these augmentation treatments, augmentation cystoplasty, where we bivalve the bladder, and it is anastomosed with a bowel segment, so that it will reduce this overactiveness of the bladder, and it will reduction of the symptoms will be there. And this is more practice we are using the treatments for like neurogenic bladder dysfunction patients as well. So, but EUA recommends basically go for non-surgical methods first, but failing that, these surgical options should be tried. So that's all in my discussion about these are the references, EUA and the Campbell. Thank you very much.
Okay, thank you, Dinendra. It's a nice presentation. Stick to the time. Manjula sir and Suren sir, do you have any comments or questions?
Yeah, I think it's important that when you're dealing with a patient with this kind of detrusor overactivity, you actually should start. There's a contribution by lifestyle also. So dietary modification plays a fairly important role. So I think that's important. Caffeine has a proven role in giving you detrusor overactivity. So just like using pharmacotherapy, we must stay away from caffeine, that is all forms of tea, coffee, cola drinks, and high cocoa containing food stuff. Yeah, I think that's the first step. And then you get on to the pharmacotherapy. And it's important that you realize that there's no one what shall I call it, one superior medication. When you're dealing with detrusor overactivity, you may have to try out different medications, because some patients it works well, while the same substance, when you use it on another, it doesn't work. So you have to, it's quite a bit of trial and error that you use. And one caution is that you shouldn't be using the anticholinergics long term in elderly people because of the cognitive impairment that theoretically there's a possibility. I think that needs to be added. That's about all I could think of.
Anjula, sir?
Madhushankar, now the tablets that you are using, the anticholinergics, how would you prescribe? What is your idea about, suppose there is a patient, even after lifestyle adjustment, weight reduction, avoiding caffeine, avoiding alcohol, still complains of some bothersome symptoms. So how do you play with these anticholinergics medicines?
So the
What would you try first
we
in
have to
Sri Lanka?
start with anticholinergics first. So we can use either tolterodine, sulfonylurea agents, but without increasing their dose of a monotherapy, we can add these other alpha 3 agents as well, sir.
Okay. Before moving into alpha, the beta 3 agonist,
Beta 3 yes.
agonist. So now antimuscarinics, what is the receptor that you are hoping to block?
So these anticholinergics are there. They are blocking this acetylcholine blocking is there, sir.
Yeah. Which muscarinic?
It's M3, sir.
M3 blocker.
Yes.
Right. So compared to oxybutynin, is there any superiority in solifenacine? Oxybutynin, tolterodine, solifenacine. So do you think is there any superiority in using this newer version?
This oxybutynin, tolterodine, they are kind of early releases there, so they will have a quick action, but the side effects are more. But sulfonylurea has a long-lasting action, so the side effects are lesser. So the patient's compliance is good in sulfonylurea, sir.
So
And
that is the thing. So, yeah, yes. Efficacy-wise, they are all same efficacy, yes. But the tolerance, the side effects are lesser for the newer medication. Suppose you set a patient up on solifenacine 5 milligrams at night, and the situation is not that better after 3 months, let's say. So what is your next option?
Either we can increase the dose of solifenacine, or we can add this beta 3 agonist.
Right. Why not combine solifenacine with a short-acting oxybutynin? What do you think? Suppose you give solifenacine at night and oxybutynin 2.5 milligrams, regular release in the morning. Compared to adding a mirabegron, what is your idea?
Because they are all efficacy same, so I don't think it will give you more action. But
yes, so you are absolutely right there. There is no scientific basis of adding anticholinergics. So if one is not working, two will equally not work, but added side effects. So yes. What is this problem of this beta 3 agonist use in this our patient population? It's a very good drug, but what is the problem? What should you be looking for as a adverse effect?
Yeah, it will has adverse effect of it will cause more UTIs, and this pharyngitis and laryngitis symptoms are there, and constipation also will there, sir.
Maybe, but the most serious problem is patients who are on antihypertensive medication might have uncontrolled hypertension. So that is a danger in elderly population. So if a patient is reacting badly for mirabegron by having accelerated hypertension, you can't use the medicine. But it's very good. It doesn't cause cognitive impairment. Okay, now you have tried all this medication, you have tried a combination, still the patient is not very happy and you are planning to move to Botox injection. Yes. Have you seen a Botox vial?
Yes, sir.
Is it a powder or a solution?
It is a powder, sir, but we can't see in the vial, sir. After adding the solution, it will dissolve, sir.
So it's a figureless powder.
Yes,
it's
sir.
Like a vapor.
Yes, sir.
Right. So how would you calculate a dose for an average built patient? Let's say 70 kilogram woman in early 50s. Now you are
Uh,
thinking of giving the Botox injection.
Yes. So
How
exact
would you
dose
pick on the
calculation, I
dose?
don't know, sir, but we usually use 1 vial for 1 to 2
One
vial
vial
for
is 100
patients.
units.
100,
One vial is
sir,
100
100
units.
units. So dose
Okay.
calculation
So
exact, I am not sure.
now how would you plan to inject this? Now you have a
We can do
cystoscope, you
the
have a long needle.
cystoscope, yes, and the long needle, and we can map the bladder, sir. We can make a small bleb in the urothelium without puncturing the bladder, without going
What is
more
the
deeper.
exact tissue level you are trying to place this medicine?
In bit, we have to go to the detrusor muscle and the urothelium in between.
So no, what I want to know is, do you do submucosal or intramuscular in the bladder wall?
Submucosal, sir.
Yes. So you have to white out, you have to create a bleb where the blood vessels will all squeeze their blood out and give a white dot
Yes.
without puncturing the muscle. But you, for a special reason, you will puncture the muscle. What is the condition at that time? What type of detrusor overactivity? There are two kinds: idiopathic,
There are,
neurogenic.
yes.
So for the severe neurogenic detrusor overactivity, you will purposefully puncture the detrusor and deposit the Botox there. But for others, you are doing this submucosal.
Sub-
How many places roughly for this 100 units? How many places do you try to inject?
So more than roughly about more than 8 places, sir. It will cover the sequential in the bladder, sir.
Yeah, you try to put about 20 to 30 blebs. What are the areas you try to avoid injecting?
The trigonal area, sir, and around the ureteric opening area, sir.
Okay. So in your consenting before Botox injection, what specific thing you had to mention and get the patient's consent? Except for these allergies, infection, bleeding.
Yes.
What is the specific
Following
thing which you need to
following
get?
Botox injections, sir, they can, some patients can lead into the retention, sir, and some
Right.
they
Very
need
good. Very good. So you need the consent to what would you write in the consent?
either they need catheterization for a period or a self-intermittent catheterization, sir.
So you should say patient understood and willing to practice self-intermittent catheter if a retention occurs. How
Yes.
long would a Botox one set of injection the efficacy would last?
I'm not sure, sir. Then.
Yeah. On average, it's 9 months to 1 year. So that is a very good time duration where you are free of medication, oral medication. Okay, good.
Right. Thank you, sir.
Thank you very much for nice discussion, sir. So next topic is stress incontinence.
I have two questions for Madhushankar. As Mandla sir said, it's work for both IDO and neurogenic detrusor activity and idiopathic detrusor overactivity. More in neurogenic detrusor overactivity, and the dose is slightly higher, double the dose we give. Normally, start with 100 units per episode for idiopathic and 200 for neuropathic. And neuropathic, it will take longer time for the response, normally around 9 months, and 2/3 will be dry, and then but in idiopathic only half will be dry. So the neuropathic, the dose is high, the duration is longer, but the outcome is better than idiopathic. I have put those trials in the chat box. Please read around those. Yes, Nishant, we'll move on.
Yeah. Next topic is sorry about stress incontinence, which will be done by Dr. Madhusanka Ekanayaka. Dr. Madhusanka, over to you.
Thank you, sir. Am I audible?
Yes.
Good evening, everyone. I will be discuss about the stress incontinence today. Regarding the little bit of definition and introduction, the involuntary leakage of urine on effort, exertion, coughing, or any cause of can cause increase in abdominal pressure. This is described due to the hypermobility of the bladder base or due to pelvic floor urethral sphincter deficiency. According to the video urodynamics, they have categorized it into 0 to 3. The type 0 is only the without clinical signs, only demonstrable incontinence, and the type 1 is less than 2 centimeter descent, and the type 2 is more than 2 centimeter, and type 3 is gross bladder, neck, and proximal urethra already open and rest, and with and also it's known as intrinsic sphincter deficiency. Regarding theories of pathogenesis of stress urinary incontinence, there are two theories. One is integral theory. There is the laxity of anterior vaginal wall and pubourethral ligaments causing bladder neck hypermobility. And the hammock hypothesis, they are the failure of support of the urethra by the endopelvic fascia and the vaginal wall. The epidemiology of stress urinary incontinence, it's more, its prevalence of incontinence is 16% in younger, less than 30 years, and it's double in the elderly population, 30 to 60 years of age. More common among female, and it's more common form is the stress urinary incontinence. And usually it is a burden in US. It's 135,000 undergo surgery for urinary incontinence in USA. And when it comes to risk factors, the female gender, the age and associated estrogen deficit, the high BMI, smoking, pregnancy, then the associated vaginal delivery, pelvic surgeries, diabetes, connective tissue disorders, and neurology can consider as a risk factor. But importantly, even though the estrogen deficits may consider as a risk factor, the HRT does not show to reduce the risk, reduces the risk of stress urinary incontinence. That is demonstrated in a randomized control trial. And regarding evaluation, the history, we have to demonstrate the type of the incontinence, and they are in the history they have formulated validated questionnaire. Then I will be discussed in the next slides. And physical examination, the pelvic examination. These are the validated international consultation on incontinence and modular questionnaire, IC, IQ, UI, short form questionnaire. In the history, we can assess. And the examination regarding the anatomic and neurological causes, the abdominal masses in male, prostate, anal tone, and the sensation. In vaginal examination with full bladder and empty bladder, and the stress test in lithotomy position to demonstrate the obvious stress incontinence. Regarding the investigation, urinalysis is a must to demonstrate LUTs, the other red flag signs such as hematuria, glycosuria, leukocyte esterase, and nitrite to demonstrate other causes of stress incontinence. And the post-voidal residual estimation with ultrasound KUB, and a bladder diary, the frequency incontinence episodes and the individual patterns of voiding. They can be a micturition time charts, frequency volume charts, and bladder diary. In the pad test, they consider as a gain of pad weight more than 1 gram per hour or 8 gram per 24 hours. And the urodynamics, the urodynamic definitions of stress urinary incontinence is involuntary leakage of urine during the increased intra-abdominal pressure in the absence of detrusor contractions. So the NICE recommends urodynamics only after when the patients fail to conservative therapy, or the patient who has undergone previous surgery for stress urinary incontinence. Because only 5% women will have POS, stress urinary incontinence, on urodynamics. And as my colleague says, that the uroflowmetry to assessment of the low urinary tract symptoms, and the cystometry, the importantly to the demonstrate the pressure volume relationship of the bladder, and demonstrate the differentiate it from the overactive bladder. And also urethral pressure profile that can used to measure the urethral closure pressure and the internal. Regarding the management of the stress urinary incontinence, initially the conservative management, including the lifestyle changes, weight loss, supervised pelvic floor exercises, avoidance of smoking, and avoidance of the constipation. And usually the pharmacotherapy is not routine due to the poor cost effectiveness to increase the urethral pressure. And in the UA, they suggest duloxetine, the serotonin noradrenaline receptor inhibitors, to enhance the contractions of the rhabdosphincter. but it has associated with the side effects, so limit the use. And as a conservative measure, they use containment devices such as pads, catheters, plugs, vaginal compression devices. And the surgical therapy usually followed with a pelvic floor MDT, as this is as there are many options, as well as this could be mixed incontinence. So initial minimally invasive therapies are the injection therapy that is reserved for frail elderly patients and the patients who are not completed the family. These are bulking agents injected intramurally. The bulk can support the urethral sphincter mechanism, such as collagen, autologous fat, carbon, and silicon. Success rates are variable, 10 to 80%, and they need repeated injection. These are the examples of urethral bulking agents. That there are synthetic and biological products, various products that made from silicon, carbon, and the other polymeric agents, and the biological products containing the porcine and autologous muscle-derived cells. And the surgical options, there are various surgical options described. The one thing is the paravaginal repair with bladder buttress, the Birch Colpo suspension, mid-urethral string procedure, and tape procedures, TVT and TOT procedures, the needle suspension techniques, and autologous sling procedures. Regarding the Birch Colpo suspension, it's the most widely used and best durable technique. There are various methods, the open, laparoscopic, combined laparoscopic, and robotic methods, and success rates are 85 to 90%. The paravaginal repair with bladder buttress is a variant of Birch procedure, and success rates are up to 85%. Here, the aim is to disperse the tension on paravesical tissues laterally. This is a demonstration of a Birch Colpo suspension. They are the retropubic approach. They have used buttressing of the Cooper's ligament into the pubocervical fascia. Then the mid-urethral sinks, the tape procedure, TVT and TOT tapes, they describe the use of soft monofilament polypropylene, more than 75% mu pore-size measures, and the success rates are 80 to 90%, and it's associated with mesh complications such as mesh erosions and infection. These are the commercially available tapes that can be used as a minimally invasive or invasive procedures. And these are the various techniques. One thing is the retropubic approach with TVT tape, the short tape procedure, and the transobturated approach. Then the autologous sling procedures, the use of retropubic mid-urethral sinks with autologous tissues. They use rectus fascia, the fascia lata, in similar short-term outcome to synthetic measures, and the artificial sphincters and devices for the patients who have SUI secondary to sphincter deficiency with normal bladder activity and compliance. That's all, sir. Thank you.
Thank you, Madhusankar, for nice presentation. Manjula sir and Suren sir, over to you for any questions.
Madhusankar, that is a good comprehensive presentation. Now, when you are evaluating the stress incontinence, what do you think the place of the urodynamics to confirm this prior to treatment?
Sir, in the guidelines, they are not in initial period. They are not suggested to go for urodynamics, because only less than 5% they suggest that the urodynamic diagnosis of SUI with urodynamics, and only the NICE guideline recommends only for patients who have previous surgeries and patients who fail conservative management. Go for this urodynamics.
Suppose you are planning a sling operation, would you consider urodynamics as compulsory?
The patient who are going for surgeries, they need, according to them, they need multidisciplinary discussions and the patients and urodynamics.
Okay. Now, do you know an idea called, now a person who presents as stress incontinence in the layman's language would be actually having overactive bladder? What is the percentage like? the patient has presented for stressing or saying, I am leaking urine when I cough, sneeze, or do any heavy work, but actually having unstable bladder.
So it's a more common one is the stress. Yes. The more common one is the stress incontinence is 50%, and other thing is the mixed incontinence usually, sir. It's and genuine stress urinary incontinence is less, sir.
So would you then consider giving an antimuscarinic as initial treatment during assessment for a stress incontinence patient? Let's say a course of solifenacin for 1 month. Because if the patient improves, you don't have to proceed.
If the symptoms are mixed, we can give a course of. I'm not sure, sir.
Yeah. So is there a way to know a patient who is having stress incontinence due to overactivity on a urodynamic tracing? Is there a way to find it out? That means you suspect the patient to have unstable bladder who has presented with stress urinary incontinence. In the wave pattern, can you identify this for sure? In the filling phase, okay, since it is taking time. Now in the filling phase, for quality control, you are asking the patient to cough at regular intervals. Do you know that? You
Yes,
get the patient to cough so that the subtraction can be noted. So you can notice when the patient coughs, patient does not only leak, there is an unstable wave in the pDET. So pDET rises after a cough, and that results in the urinary leak in the urine collection container. So if that is repeatedly noticed, then you can consider that this patient is having stress urinary leak being manifested, but the underlying cause is a detrusor instability. So that can be picked up if you have done that. Okay, I'll move on to another question. Now, what do you think the current status of this artificial sling operations for urinary incontinence? What is the current situation? Is it in practice? Is it in now practice, or is there a problem? This TOT, TVT, are they in use?
So in UK there are problems. I am not very sure because of the
The problem is there is a commission which has sat on the, they have done an audit about these problems where the females who have got the sling operations done, and they are having a review. So from 2018, this sling operation is not being practiced. So what is the substitute if the artificial slings are not there? How would you do the operation? What is the new method?
We can use rectus fascia or the fascia lata as autologous.
That is called autologous facial sling. So what are the material that you can use for this autologous facial sling operation? One is, of course, yes, a rectus, piece of the anterior rectus sheath from the patient. What are the other material you can use?
So the fascia lata.
Fascia lata from the patient. Actually, it is fascia lata from cadaveric fascia lata or genetically engineered facial slings. So all three are possible. But the best would be you're harvesting from the patient itself. So what are the two types of stress incontinence pathology-wise? What is wrong with the urethra in the two situations, which can give rise to this?
One thing is the hypermobility of the urethra, and other thing is the intrinsic urethral sphincter deficiency.
Right. So both of these are addressed by the autologous facial sling.
Right. Yes.
What is the gold standard in incontinence operations?
It's the Birch call for suspensions.
Yes, even up to now, that is the surgery that is considered as a gold standard. It's very good. So that is your matching for. Right. Suppose after your sling operation, patient goes into retention. That means your the tightness is more than what is expected. So how would you treat such a patient? Patient has gone into retention after the operation.
Sorry, sir, I know.
Okay, so that treatment is not very certain, but you can try a gentle tug on the urethra. You pass a dilator into the bladder, and you gently, retract it towards the rectum and try to lower the sling, because there is no satisfactory treatment if you get it tight. Okay, Suren, over to you.
Thank you, sir.
Yeah, Manjula, I think you've dealt with most of the things. Yeah, nothing much to add, Manjula. Yeah.
Thank you, sir.
Okay, thank you, sir. So next
I
topic
have,
is
yeah.
okay. Yeah.
I think as Manjula sir was expecting these trials, I think he was is stressing to get down the names of trial because it's an exit exam. Better to support your answers with landmark trials. I think Manjula sir was expecting this value trial, the evidence of aerodynamics in stress urinary incontinence. Madhushankar read around that trial. Another thing, Manjula sir was stressing about this types of operation or intervention. It all depends on whether it is intrinsic sphincter deficiency or hypermobility. If it is hypermobility, you might go for birch pulp suspension rather than slings or bulking agent. If it is sphincter deficiency, you will prefer either tapes or bulking agents. All depends on urodynamic study. Because if you are going for intervention, we'll do a urodynamic study. And then depending on the Valsalva leak point pressure, whether if it is less than 60, it is going to be IST. If it is more than 90, it is mostly due to hypermobility. And if it is more than 150, it is less likely to be any due to any urethral anatomical abnormality. Yeah, read around that value trial.
Okay, sir. Thank you.
Thank you, Taha. Next topic is pelvic organ prolapse, bladder pain syndrome, and interstitial cystitis. Speaker is Dr. Muhammad Nabil. Dr. Nabil, over to you.
Okay, thank you, sir. Yeah, I'm going to discuss about the pelvic organ prolapse and the bladder pain syndrome. So, in compared to the epidemiology of the pelvic organ prolapse, usually 50% of the women usually develop after the birth, childbirth. Most of the time present to the gynecological stream or the urological stream. When there is a low urinary dysfunctions are there, the most of them are present to the urologist. So this lifetime risk of pelvic organ prolapse and incontinence surgery is around 11%, and with 29% requiring repeated procedures. So most of the time, this patient who have undergone a surgery, they may require the repeated surgeries. And anterior is the most commonest the weakness, 50% of them, posterior 30%, and the 20% occurring in the uterine wall prolapse. So in the elderly population who has around 6.3% of the women who have undergone operation to correct prolapse by the age of 80. It's a normal the incidence, but usually this some of the epidemiology are lacking because of the presentation and their symptoms are less, not bothers, and they not present to the clinics. So these symptoms are much less. The evidence, incidence, and the prevalence are much less when compared to the true incidence. So when with the anatomy, we have to understand there is a level 1 and the level 2 and the level 3 supports in the perineal region. I have mentioned in the diagram where the level 1 supports the usually the cervix and upper vagina with the cardinal ligament, with the uterosacral ligament. And the level 2 where around the paravaginal endopelvic fascia covering the levator, which is attached to the white line of the levator, where it supports the mid part of the vagina, and the lower part where it supports through the perineal muscles and the perineal body. So if the weakness occurs among them, it occurs in a different levels, and which will cause the different kind of presentation and different symptoms. So when about the etiology, usually it's the acquired one, but there are congenital causes as well. We have to think about the Ehlers-Danlos syndrome like congenital collagen vascular disease and spina bifida and other congenital anomalies, ectopy, bladder ectopies. And some acquired ones are related to the previous vaginal surgeries and previous corpus suspension or previous hysterectomy. And commonest one is the vaginal birth and old age. And with the history of other risk factors, obesity and constipation and chronic straining, which will promote this pelvic floor weakness. So current basis of concept of this pelvic floor weakness, widening of levator ani hiatus due to the birth trauma, which will create the low pressure area in the vagina, consequently increase stress on the ligaments and fascial elements and pelvic muscles during the physical activity. When supporting the function of the muscle and connective tissue fails, the pelvic organ collapse will develop. So when you look at the classification, the anterior wall collapse, which is usually herniation of the bladder or cystocele or urethrocoele through an anterior vaginal wall due to weakened pubofiscervical ligaments. Posterior wall collapse is a protrusion of the rectum through the posterior vaginal wall due to weakened perirectal fascia or protrusion of peritoneum via small intestine or omentum into the vagina. That's called enterocele. So other than the middle part compartment collapse, which include the uterine collapse and the wall collapse after the hysterectomy. So there are grading and staging systems with the evolution from the past histories. They have separate classification. This is one of the Baden-Walker classification. This was in 1968, but now grading system have evolved. This is from 1963. There are staging system. We have considered the first degree and second degree and third degree UV collapse, which have occurred. The first degree is within the vagina. Second one is beyond the introitus. Third one is complete extrusion of the uterus, having a total vaginal collapse. So now is evolving. The 1996 have evaluated that quantitative pelvic organ collapse quantification. We have the Incontinence Society to have developed this category staging system, where the stage 1 into within the introitus, but above the 1 centimeter the hymenal ring. The hymenal ring is taken as an anatomical point, which have the demarcation. So 1 centimeter within the it means above the 1 centimeter of the hymen is considered the when it prolapse within the introitus, considered as a stage 1. The within -1 to 1 centimeter, the hymenal range, the prolapse is considered as a stage 2. Beyond 1 centimeter from the hymenal ring is considered stage 3, where total prolapse of the vagina considered the stage 4. This is the now currently practiced the staging system for prolapses. And the clinical presentation. So this is commonly they have usually having 80% of the people have only the symptoms related to the bulging and the vaginal pressure symptoms, except the lower urinary tract occurs in less than 20% of the people. So in these, because they are sometimes not demonstrable, so only the examination we encounter it. So that's like a increased urinary frequency, urgency, and incomplete blood emptying, and some are coming with this stress incontinence and mixed incontinence features. And other things are bowel dysfunction, where it occurs with the posterior prolapse, where urgency and difficulty and defecating difficulties and fecal soil. Some related to the prolonged standing, they can feel the heaviness and the pressure symptoms. Sometimes they want to reduce the manually to void or defecate. So the other thing is mainly sexual dysfunction like dyspareunia and lack of sensation. So the functional problems mainly bladder functional and the bowel and the sexual dysfunctions are associated with this prolapse symptoms. So examination wise, we have to do the lithotomy position and left lateral position with Sims speculum, and where you have to look at the anterior wall, usually more than one compartment involved. Then we have to demonstrate, and with compressing the posterior wall and look at the anterior wall, and the compressing the anterior wall, look at the posterior wall, and ask the patient to cough and bear down, and we have to observe any retraction or bulging of this or prolapses to the introitus. So these things has to be done. Other things we have to do the demonstrating stress urinary incontinence are usually masked by these prolapses. So you have to demonstrate with reducing the prolapse and ask the patient to cough and demonstrate the stress urinary incontinence. In the guidelines, also in the EUA, the pelvic organ prolapse and the reduction test should be done with the in a continent woman to identify the occult stress incontinence. So investigation wise, when the patients come to the clinic, this is usually evaluated with excluding the underlying tracts, mainly infections, and the way these usually you have urine analysis, and they have to measure the functions. And other things are residual volume, where we measure any residual because concurrently if there's infections and the retaining of urine, which will cause the problem of the patients, and the recurrent urgency and the frequency and nocturia. Those things we have to assess the post-viral residual, and urodynamics is only concomitant, only the voiding dysfunction or incontinence. So that is a nice guideline. Don't include the recommendation to perform urodynamic as a part of the diagnostic workup of pelvic organ prolapse, except for combination of symptomatic stress urinary incontinence. So in MRI or the difficultography, these are done in complex cases of traumas and perineal traumas and complex injuries and recurrent operations, which should not have given the results, and then when this can be considered in the later part. So management-wise, we have to know the non-surgical management have to play the role. Mainly lifestyle intervention mainly we have to educate about this heavy lifting and weight gain, and the constipation has to be treated, and the chronic cough has to be treated. And the pelvic floor muscle exercise is the one of the very supportive and therapy for this initial part of workup who has not needed the surgical management. So those who coming with the lower urinary tract symptoms with pelvic organ prolapse, if you are considering a conservative approach initially, the pelvic floor muscle training is in a supervised and individualized manner. We can consider that have a more beneficial effects and have a good outcomes. And a vaginal, when other thing is a vaginal pessaries. So these are still considered and is a good treatment options for a patient who is having a UV prolapse and we are mainly considering the conservative approach, and with the elderly not willing for the surgery if there is no any other associated urinary incontinence. So better this will be a better option, and the literature also available. We conclude an effective and safe option for around 70 to 92% of patient satisfaction. So we have to consider if a reproductive age, the life the expectancy and developing recurrent problems in the lifelong, so sexual function, and those things has to be considered. And with that, we have discussed and have to give this vaginal pessaries. So this the recommendation by UV, where informed women and pelvic organ prolapse who don't need a vaginal pessary or surgical intervention, and about the potential relief from the lower urinary tract symptoms from the pelvic floor muscle therapy alone. That is strong recommendation. So don't offer preoperative pelvic floor muscle exercises in order to improve outcome of LUTS if pessary therapy or surgical intervention is indicated for pelvic organ prolapse. When we come out this,
5 minutes.
Yeah, surgical principles of surgical repair. Mainly the prolapse require the treatments. More than one types will be there. So primary repair is performed using the absorbable intraepithelial buttress sutures. So we are the even anterior and do the correction surgeries. We are not using the mesh. That is more important because of the mesh complications, mesh erosions, and the chronic pelvic pains. Now that is not now is out of the way for the primary repair. So the anterior compartment where this vaginal skin is opened in the midline and dissected off the underlying tissue and the bladder, and suture repair, which is called plication techniques, we usually consider, and anterior colporrhaphy, the interrupted sutures which are placed from the remnant fascia on either side of the prolapsed bladder. So these are tied together over the prolapse to reduce the back into place, and excess vaginal skin part is excised and the suture that will be corrected the anterior vaginal prolapse. So failure of this rates around 29% when compared to this failure rate of suture repair is 29 is 9% for non-absorbable mesh repair. But even though now mesh repairs are considered because of the complications, other things posterior repair compartment repair with suture technique is the same, but failure rate are similar around 50 to 20. Risk of bowel injury and bowel symptoms and dyspareunia are the problems. And middle compartment prolapse, where the wall prolapse, where uterine prolapse include vaginal and abdominal hysterectomy. But the hysterectomy, there is no abnormal pathology in the uterus, but even though these are considered in the UV prolapse with the vaginal hysterectomy. So alternative for women wishing to preserve the uterus, we can do the sectohystopexy or open or laparoscopic approach may be taken. So strip of mesh encircle the cervix, then suture to the sacrum. That is the technique. And when the wall prolapse, what we can do is we can do the sacrospinous fixation through the vagina, or through the abdomen. We can do the laparoscopic or open sacrocolpopexy, which can suspend the anterior and posterior aspect of the vaginal wall. Other things, uterine ligament suspension to suture the uterosacral ligament to the vaginal apex. So here, other option is colpoplaxis, where we can do the sexually non-active woman. We can even put a prolapse within and close the vagina with the removing the part of the vaginal wall to reduce the prolapses into the introitus and reduce the symptoms. So offer simultaneous surgery for prolapse. Being considerations are when there is a stress urinary incontinence, vaginal and pelvic organ prolapse, the best option will be if there is anterior vaginal wall prolapse, the birch colpo suspension will be a good option. That will be a gold standard. But when you do the pelvic organ prolapse, patient should be educated about the post-operative urinary incontinence and stress urinary incontinence. So when we have to identify stress urinary incontinence before go ahead with the pelvic organ prolapse surgeries. If it is that, we have to do the sling procedures and this pelvic organ prolapse surgery in a combined manner. But even that, we have to discuss about the pros and cons about this treatment modalities. So thank you about this pelvic organ prolapse. Other things I have just included about the bladder pain syndrome. It's a poorly understood condition where I have a chronic pelvic pain, usually called interstitial cystitis. It's called painful bladder syndrome, usually difficult to diagnose, as there is no single test that confirms the condition. The BPS can be affected the people of all ages and much more common in women than in men, and usually over the age of 30. Symptoms are usually intense pelvic pain, sudden onset of sometimes cramping-like pain in the lower abdomen and with the lower urinary tract symptoms, mainly the urgency, frequency, and irritative symptoms, and nocturia. And we mainly have to evaluate the pathological condition underlying mainly urine test to exclude the urinary tract infections, and the cystoscopy to evaluate the underlying any chronic conditions have to exclude by the pathological diagnosis. Sometimes even if there is any cystitis changes, have to take the biopsy and confirm it. Other thing, visual description of any underlying ulcers and underlying bleeding and cystitis changes, you have to look into. And other things, according to the underlying pathology, we have to use the urodynamics and the imaging modalities when there is necessary, if there is a chronic problem, other surrounding structures problem when we are thinking of. So management wise, initially ideally the pain management, medical management, and give the supportive and some are long-term problems, some we have depressive antidepressants and the neurogenic nerve pain, neuralgic pain management, and the anticholinergic management are the main option for the medical management. When you talk about the bladder installations, we can give a local anesthetic installation with the catheter, with including some steroids, sodium bicarbonate, heparins are used, but currently now not practiced. The hyaluronic acid, chondroitin sulfates also used, but now not practiced. These things are antibiotic alone and combined with local anesthetic and steroids also can be used, but in the nothing is now practicing the bladder installations as except local anesthetics. And the physiotherapy wise, pelvic floor muscle exercises to ease the pain, and the supportive measures and the transcutaneous electrical nerve stimulation are the one for the supportive management and the counseling of these patients. That is the management for the long things. And interventional procedures are we can do if there is ulcers, we can cauterization, and the irritable bladder, when there is irritable bladder, we can give the botulinum toxin injections and the neuromodulation for the patient which is having a long-term problem. So if it is even not settling, we even consider there is option for a cystectomy in the later part if the even not settling for any kind of management. Thank you, sir.
Thank you, Nabil.
Yes.
We'll move to third panel. Manjula sir, Suresh, any questions, comments on this topic, sir?
Look, regarding the first part, as you know, we are not experts on that at all, but it was very, very well done, I thought. And for the bladder pain syndrome, I think the practical point is when you're confronted with a situation like this, it's important that this is almost a diagnosis of exclusion. So you have to start with very simple tests and work it out from your urine to the cystoscopy. You have to really, it's a diagnosis of exclusion, and only then should you label someone as bladder pain syndrome. It's a dangerous diagnosis to make as the first or very early. It has to be sort of made after you've ruled out everything else. I think that's all. Otherwise, it was a good presentation.
Nabil, I also have a question for you. Now,
Yes.
what are the important urological diagnoses that you need to exclude before labeling a patient as bladder pain syndrome?
One thing is an important one, urine malignancy. You have to exclude irritable bladder things which can cause irritable symptoms, same as the infiltrative disorders. And other thing is the recurrent urinary tract
What
infection.
is the specific malignancy you are thinking?
Thinking of invasive malignancies which can give rise to pain, low pain, which can involve the trigone, squamous cell carcinoma.
No, it is not the histology type. It is actually not an invasive carcinoma that you are trying to exclude, the number one malignancy. It is not an invasive carcinoma. What it is? What is the most dangerous transitional cell malignancy in the bladder in such a situation? If you miss the patient circumstance. Carcinoma in situ, very good. That is the one.
Yeah.
So carcinoma in situ is one. What are the other conditions you want to exclude?
Chronic cystitis and TB cystitis.
Very good. It's Mycobacterium tuberculosis. That is the other mimicry of interstitial cystitis. So if you have excluded these two, you have covered most important things. Okay. Then have you heard of a treatment option called cystodistension? What is the place of cystodistension when you suspect the patient is having interstitial cystitis?
Patient.
Did you come across any
installation of the come across just today only I just got to know, and I just not gone through much on that as a with the we can give installation with the patient not responding to, we are diagnosing intestinal cystitis. After that, if it is not responding to the medical management, we can give installation and see if they stretched out the bladder.
It's not installation. It's not called installation. Installation is a cystostat insulation or some chemical into the bladder. This is called cystodistension. Cystodistension is the term. So, what do you think the place of cystodistension in interstitial cystitis? Does it have a place? Now the problem is traditionally urologists had no treatment for this condition. So they were giving the cystodistension and patient got a transient improvement. And that's how the urologist discharged the patient from the treatment, because he knows she's not going to improve. So cystodistension will get the patients sufficiently satisfied to go home. Otherwise, the patient will protest and stay in the ward without getting discharged. So that was a method to discharge a patient. So if you are doing a cystodistension, how much of pressure would you try to generate in the bladder? Now you have to fill the bladder with the cystoscope. What is the pressure you are thinking of, the cystodistension pressure? It should be less than 100 centimeter water. So let's say it's 80
no
centimeter.
idea, sir.
It's like 80 centimeter water. And holding time, you fill the bladder with a jug kept at 80 centimeters from the symphysis pubis and hold it for about 2 to 5 minutes and release. So if you are keeping the cystoscope in the bladder and after cystodistension, you are observing the mucosa, what is the cardinal, some diagnostic thing which you can observe in the bladder mucosa? So after cystodistension in interstitial cystitis, what is the finding in the bladder wall, bladder mucosa?
There is a mucosal, ecchymotic rash, like ecchymotic patches, like things.
What do you call it? What do you call it? It's called glomerulations. Yeah. So some parts of the bladder wall, like a glomeruli, will start to bleed, and there's cascading like waterfalls of blood appearing. So glomerulations in the bladder mucosa is considered a feature of interstitial cystitis. So at the time of cystodistension, you can spot this. Why do you think cystodistension is we are not seeing them here? Because now if you're answering a question for some British urological exam, this is a very common topic for asking a question because they are seeing it day in, day out. Why do you think we are not seeing it in Sri Lanka?
One thing is patients clinical conditions is presentations are rare. One thing, other things after coming, patients have gone here not back following the patient because not getting treatment here and there, not following the same the current clinic follow because patient not have satisfaction.
Yes, Nabil, you're spot on. Here, we don't consider it as a differential diagnosis. So we think it is chronic cystitis and give some antibiotics, some painkillers. After some time, the patient gets fed up with you and will move on to a next doctor. Next doctor also will treat it for infection or pain relief. Nobody will diagnose it interstitial cystitis, so we won't have a reported number. But it may be there. And the patients also not demanding from their urologist to see, doctor, is it interstitial cystitis? So there is no diagnosis made. But it is a very common diagnosis. If you can't find anything, it is labeled that interstitial cystitis, and patients will ask for disability allowance if you diagnose them with interstitial cystitis. So it's a very common problem the urologists of the developed world are facing. Okay, thank you.
Yes.
Thank you, Manjula sir. One more thing, as Manjula sir said, you can see this glomerulation, and then you can see this Hanna's ulcers. There's bleeding from the mucosa and submucosa. And do you know any classification of or definition of interstitial cystitis and the classification or cystoscopic classification of interstitial cystitis, Nabil?
No, sir. I have only prepared the pelvic organ prolapse and just I have not gone through, sir. Sorry.
Because of that, as Suren sir said, this is like an diagnosis of exclusion. We have to exclude sinister or red flag pathology. Now, there is an NIDDK definition, inclusion criteria and exclusion criteria to diagnose interstitial cystitis, as well as European Society of Studies of Interstitial Cystitis. That's a cystoscopic grading or the types of interstitial cystitis. They have numbered 1, 2, 3 for the finding during the cystoscopy, 1 for normal, 2 for glomerulation, 3 for Hanna's ulcers, and ABC for the biopsy, whether it is normal, inconclusive, or positive. And then, as Manjula sir said, this patient counseling is very important. We have to tell the patient this is the diagnosis, probable diagnosis. There is no cure for this condition, but we can control the symptoms with medication. So read around those ESIC and NIDDK classification and pathophysiology. There are theories about stress. There's female preponderance. There is play of hormones, urinary tract infection, chemical, and pathogenesis also read around interstitial cystitis, pathophysiology. Anything else, sir?
No, I think you've covered everything, Taha, very well.
Manjula sir, anything else to add?
I think looks all right. I think the candidates needs to know this abbreviated famous studies, no?
Yes, sir, definitely, sir, because they have to come out with, they have to support their question with, answer with landmark trials. So that would be expected. So we have shared a table of landmark trials with them. So I don't know whether they haven't noticed that, or they might have forgotten their busy schedule.
Okay.
And there is one more thing, Nabil. There is interstitial cystitis. There is scoring system also. Interstitial cystitis symptom index and interstitial cystitis problem index. There are domains and scoring. So just to know the names.
Okay, sir. Okay, sir.
Yes, it's a hot topic, and they might be any exams. Nishant, anything you have?
No, Taha.
Before winding up this session, I have a message from Professor Ajit Maradasekara. The MCQ test date, it is confirmed. It will be on 25th of August. So 25th of this month, and it is confirmed. And he wanted me to encourage senior registrars to apply and get ready for the exam, because Uromet, all the topics, almost everything will be covered before your exam. And I hope we had a nice session this evening. I would like to thank our expert panel, Dr. Manjula Vijayardhana, Dr. Surendi Silva. Thank you very much, sir, for accepting our invitation and sharing your experience and knowledge. Thank you, sir.
Thank you, Taha.
Thank
Pleasure.
you. Thank you. Pleasure.
And I want to thank my co-moderator, Dr. Nishant Veerasinghe.
Thank you.
And I want to thank all the speakers, starting from Dr. Niranga, Dr. Prasanna, Dr. Madhushankar, both Madhushankar and Dr. Nabil, for their preparation of their talks. And then, for the last, not for the least, I want to thank the sponsors, CIPLA, for arranging this Uromet session. So we had a nice discussion, and read around the topics we have given in the chat box, and we'll meet the next Uromet next week. Have a good evening and a nice weekend.
Okay. Thank you, sir. Good night, sir.
Thank you.
Good night. Good night.